Seminar. Liz Flannery. I'm the Director of Education and Leadership here at the American Institute of Dental Public Health. And we're so thrilled that all of you are joining us here today to have our guest speakers, Dr. Adam Barefoot and Maria Ferraris, with us here today to talk about some mobile healthcare solutions. As you come in, I invite you to join us on camera. This is designed to be an interactive session with discussion. So if you are able to be on camera, we would love for you to do so. Again, just going I'm going to kind of go through some housekeeping, some agenda pieces, and then I will hand it over for our presentation with Adam and Maria. So again, our didactic presentation today is going to be the mobile dental care model, scaling access to care for communities. We will have time for engagement, for hearing from you throughout, and we will also have time for Q&A at the end. We would love to have a conversation with you. And we will end with next steps, part of which we will talk about directions and instructions for obtaining your CEUs after this session. Okay. And Shayla, I'm just making a note. I think I'm seeing some AI note takers. If we could, I'm getting some notifications on those for the waiting room. Thank you. I'm mentioning Shayla Stewart, my colleague, is with me here today. She has AIDPH on her Zoom name. If you're having any Zoom issues or need assistance, you can direct message her in the chat. Some other housekeeping pieces. This session is being recorded. We will post the recording and session materials to include the slides on our Academy after the session. We will email that out so you can go back and see the materials, the recording, and if you have colleagues or peers who you would like to see this presentation, you can share that out as well. I mentioned that we want this to be engaging. We want to hear from you. And just a note, we want to make sure we're avoiding PHI in this session when we are sharing out. We invite you to take a moment and share your name, your email, your organization in the chat so you can connect with your colleagues and we can hear about the work that you're doing as well in your communities. And again, Shayla is available if you have any questions on Zoom. If questions occur to you as we're going through our session, please pop those in the chat and Shayla will find a time to make sure we get those answered as we go through our presentation here today. Okay. I have mentioned engagement several times now. We're going to have time for discussion, but we also want to hear from you through some polling mechanisms. And to do that, we're going to use the platform slido.com. If you haven't used this platform before, it's pretty straightforward. You can type in the email address here and then plug in this code and you'll come to our event, or you can just pop out your phone and scan the QR code here. We're going to use this a few different times throughout the session here today. So once you pull it up, keep it up and the polls will populate as we get to them. Okay, so before we dive in, we're going to talk a little bit about AIDPH, who we are, and why we're here doing this work and holding these seminars. I think many of you have been on our ECHO or our Rooted seminars before, so welcome back. You're probably familiar with us. For those of you who have not, welcome, and we're excited to share a little bit about who we are. Our mission, we're a 501c3 nonprofit, and our mission is to empower our community to advance oral health through science, education, and advocacy. And I think you'll see all those pieces here in our session today. We do this work because we have a vision of a justice-oriented oral health system. We have 4 communities of focus at AIDPH to include LGBTQIA+ communities, veterans, people with disabilities, and people living in rural communities, which is what we're here talking about in this seminar series. But of course, focusing on rural, we also understand that there is a fair amount of intersection amongst our communities. Just looking at this, and for example, veterans disproportionately live in rural communities, and that can often double the impact of disparities that these communities face. Okay. I mentioned the AIDPH Academy. That is our digital learning platform, and it is where all of our content is housed. We strive to offer a broad range of programming so that there is something for everyone and the time commitment you have available to advance your oral health education, whether you're a clinician or a public health practitioner. On the Academy, you can find everything from workshops and webinars like this, certificate programs, all the way up to more intensive week-long or year-long fellowship programs. And we hold an annual convening every year, which is our colloquium. The Academy is where our CEU information is housed, and again, we'll share information on that at the end so you can submit your request for your CEU for this session. These are our session norms, just noting and acknowledging that we're coming together for discussion and community. So we want to make sure that we are engaging in a respectful way. We mentioned no PHI earlier. Again, inviting you to be on camera, making sure your name is added to Zoom. We invite you to add your pronouns. When you are sharing, please introduce yourself and your organization and come with limited environmental distractions. This is a note here that this seminar is part of a series. We hold a rooted seminar series every year with a different theme. Our theme this year, to match our colloquium, which is how we launched 2025, is dental care is a human right. And we're exploring how recognizing dental care as a human right can drive policy, advocacy, and innovation in rural communities to advance oral health access. Also noting that on the Academy, if you have not previously attended the seminars in Rooted that we have had to date this year, you can go back and view those sessions. You can obtain CEU for them. And if you attend all sessions, either live or asynchronously at the end of the year, this is our second to last session of the year. We will have one more in November that you can complete competency quiz for each and earn a certificate. Our presenters are not sharing any disclosures here today with us. And without further ado, I'm going to pass it off to Dr. Adam Barefoot and Maria Ferraris. And I would love it, Adam and Maria, if you are able to give a little bit of your background and bio as you get started with your presentation.
Sure. Well, I really appreciate you having us here today. Worked with AIDPH for a long time. It's a wonderful organization, so thank you for the opportunity here to present today. My name is Adam Barefoot. I serve as the Chief Dental Officer for a company, Mission Mobile Medical. We're going to talk to you today from the perspective of mobile healthcare programs, specifically dental programs, and the impact they can have in rural communities. As former Chief Dental Officer for HRSA, Health Resources and Services Administration. Before that, I was the State Dental Director for the Georgia Department of Public Health. And prior to that, I spent about 8 years working in a federally qualified health center as a dental director. And so I think me and Maria are going to tag team this, but I'll let her go ahead and give her brief intro, and we'll go from there.
Hi, everybody. Thank you for having us. So my name is Maria, and I work in mobile healthcare all around the country. My background is I came from the University of Miami, where I was the director of pediatric community programs. And so we had 13 school-based health clinics, and then we had 4 mobile clinics that connected about 181 schools around Miami-Dade. And so my interest became as an obsession to the model. And then right now, what I do is I serve as the executive director for 501c that is called the Global Mobile Healthcare Research Consortium, in which we link universities and research partners with community organizations that are providing healthcare in one or the other way. And then we help fund some of these initiatives. So that's where my background.
All right. I think if there's no other question, starting housekeeping things, we can move to the next slide. So some objectives today is to start out with just kind of a broad framing of the burden of oral health for underserved communities, particularly rural. I will say I talked to some more dental focused groups as opposed to medical or non-dental people. So, given the time constraints today, I don't need to preach to the choir. I have a feeling a lot of people already have a little bit of that framework. I really want to focus on really kind of dive into mobile health programs. Everyone's probably familiar with them, have heard stories of them, have heard anecdotes of them working well, working not well. So we want to kind of give some high level overview of what really can make the best impact, can increase chances of predictability, sustainability, and even some things we've kind of learned along the way to make it scalable, generalizable going forward. We want to have an open dialogue. We want to explore and strategize. We want to hear from you. And we've kind of structured this presentation so we can cut out some slides or kind of fast forward through some slides if there's a little more engagement, if we're feeling a little more like our listening ears on, and we're going to sit back and just listen. That's fine. We've got content for that too. So we'll just see kind of how the flow goes. But definitely want to learn from you as well. Use this opportunity as a collaborative learning moment. And then kind of finalize, discuss them, and kind of reinforcing building predictable and sustainable community-based programs. So next slide. So I could spend 30 minutes, and I was talking to non-oral health folks, really just diving into the burden of oral health disease. I have a feeling that most of you have some sort of foundational knowledge of this, but just some high-level stats, especially when we're talking about rural areas. About 60 million Americans live in rural areas, which, when we think about rural, we think about, oh, this is very, dispersed, not very high population density. We're not talking about a lot of Americans. It's unfortunate, but, we're talking about small towns, large geographic areas, small numbers of people. But when you aggregate it, we're talking about 60 million Americans, about 1/5 of the country overall. And these individuals, through challenges of access to care, are going to have a lot of increased disparities when it comes to mortality, chronic disease, things associated with oral health and how they overlap with overall health. About 42% of rural adults report having unmet dental needs, and a lot of that is due to a variety of factors, but a lot of it has to do with not having a dentist in the community or a point of care, access to care. Just about 14% of dentists practice in rural communities. And while we champion, we support, we have, this isn't a knock on the brick and mortar model, but we just know between practical considerations, brick and mortars sometimes aren't sustainable in rural communities. We've heard more and more stories of rural hospitals shutting down due to funding. They may not have the capacity to be open 9 to 5, 5 days a week. But there is a need there. It's just, how do we meet that need based on the demand of the community? And we think that mobile clinics can modernize that and really be considered like satellite clinics on demand. It's not necessarily, a mobile van that's just going through a community, doing some screenings, doing some education. I have participated in those models. I have nothing against those models, but that isn't a comprehensive solution in our view. And so how can we build out predictable, sustainable programs that are there embedded as part of the community, even if they're not there 5 days a week in a brick and mortar building? Some things to consider is, we're facing a lot of unknowns right now, a lot of transition when it comes to funding, when it comes to Medicaid and Medicare, some possible cuts. I can't say that I know how all this is going to unfold. I don't think any of us do, but it's something that many are preparing for. On the flip side, if we're looking at some opportunities, there is the Rural Health Transformation Program that is allocating funds. And so how can we be strategic as these programs come down the pipeline, especially in rural focus settings, to make the most of those funds, optimize programs to reach those people in need. And again, this is more than just oral health. We all know about the oral systemic connection and how that overlaps with overall health. And so, even beyond oral health, how can mobile programs address chronic diseases, hypertension, hemoglobin A1C, other chronic disease factors that are contributing to oral health problems, but need a component of their own to be addressed. So next slide. Okay, so with that, Maria has amazing knowledge of mobile health programs broadly. So I can serve as kind of the dental nuanced voice, but a lot of what she has to say when it comes to mobile programs really translates from primary care, behavioral health, whatever it is, over to dental when it comes to bringing care communities. So I'll let her discuss our model a little bit. Next slide. Oh, I think we have a poll before we jump into that. So
yeah.
And just a reminder for folks, if you pulled it up, just go to where you pulled it before, or you can scan the QR code here or plug it into your browser here.
Yeah, so we just want to kind of take an initial assessment of the room of, are you working in a very direct, intentional way with mobile programs? Is it something you're sort of tangentially aware of in your state? You may not be working directly, but their presence, versus really, not working or aware in any capacity. I'll say so far this is I had no idea where the results would be with this, so I don't know what percent we have reporting yet, but it looks like at least about half, or have a at least pretty direct touch point with mobile healthcare programs.
Yeah, and I can toggle back whenever works.
Can you leave the poll running while we continue the presentation?
Yes,
Okay.
thank you. That's a great question. So yes, this will remain. Folks can keep going back and continue answering even when we go back to our slides. We'll stay open.
Okay. Maybe we should move on to the next one then.
Okay.
And one more. So I don't know if people have done with the last question, but I thought it would be good to start with a negative and end with a positive. So we have a poll of what are some of the challenges for those that are working with mobile, or maybe you aren't because you've had challenges. And you know, you don't have to write a paragraph, but just what are some of the biggest challenges you see in your local communities when it comes to adopting, scaling, implementing mobile programs?
And I see folks are typing, so that's great. We'll take folks a minute to fill in here versus click a button. If you're having any tech issues, we'd love for you to answer on Slido, but if you're having tech issues, you can chime in on chat and Shayla will call those out for us. And again, you can always just plug it in or scan the QR code if you don't have Slido already up.
I'm already seeing themes.
Yeah, this is a full disclosure. So we typically do a word cloud, but we haven't done the short answer piece, and I'm seeing an aggregate across the top. I'm assuming folks can see this too. So that's kind of cool, pulling in the themes.
And I don't know if you're able to compile these and send them out after. We'll try to talk about as many as we can, but I think it'll be good to get our minds around, you know, a total consensus at some point and really dive into it, even if it's after the presentation.
Yeah, absolutely. We love to do that. And again, this is for us to hear from you, but the community conversation piece is so important. So learning and connecting with your fellow stakeholders and colleagues, we will definitely share out this feedback for you to continue. And for folks who are watching it asynchronously too, they'll be able to access it in the materials section. If you're watching asynchronously, click over there. We'll have posted it.
Do we think everybody who wants the QR code, have we gotten it, and we can probably continue to take responses, but maybe move on to the next slide? Okay, I'll turn it over to Maria.
Okay, so those responses come as no surprise, as you guys can probably figure that out, because it's all about sustainability, really. Most of the time, the issues come on how do we sustain this? How do we staff them the right way? How do we put them in the right place? And what do we do to figure that out, to figure out that plan? So the goal of mobile clinics, really what they're trying to do is they're trying to figure out the barriers of geography, transportation, of course, but also distribution of care. And that's kind of how we center the whole mobile modality, is how do we distribute care to places where there is none? And there are different ways to do that, but mobile healthcare has proven to be successful in building that and operating in communities where you have no access. And so we'll go through the next slide, please. So in defining mobile clinics, we know that a mobile clinic is taking medical infrastructure, is taking providers, and is taking resources out, right? But one of the most important things, and I think that's where a lot of healthcare organizations, and not specifically maybe just dental, but healthcare organizations worry about how will we take it and how do we pay for it when it's just being there parked, opening the doors to everybody, and we only get 4 or 5 patients, right? And the reason why is because we're not treating it as a satellite clinic. And that's our best practices said, what we have to do is we have to always, understand them as satellite clinics. You're taking your brick and mortar and putting it on the road. So the same services that you can offer in your brick and mortar, you should be able to offer in a mobile modality. They, of course, offer agility, equity, and scalability. And we're going to go a little bit through how do they offer that. But just to give you a point of data is that usually mobile clinics, satellite mobile clinics, provide about 4,000 plus additional patient visits per year. And it also, so this is kind of what I was talking about, it manufactures visits, but it also retains those volumes because it allows them to be in a rotational basis. And the other thing is we talked about transportation, we talked about geography, but we haven't mentioned the 2 ones, which are provider shortages. That's how they help. So even if you're going to do some type of teledentistry or some type of thing, what is going to help is it's going to help on provider shortages and delay of care, right? When you take the care to the community, the care is not being delayed as well when the community has to go to the care. So next slide. Okay, so this is a lot, but there are 4, we kind of put the process of mobile healthcare in 4 categories, or not categories, order of things that have to be done. So number 1 is data analysis. And then we have to assess the model based on that data. Then we engage, deploy, and then we maintain and optimize. And these are 4 things that sometimes, whether it is a community health center, a hospital, or a private practice, what they're trying to do is they're trying to put these mobile clinics where they fit, or put the mobile clinics where there's a Walmart, or that's just not it, right? So best practices said, we take data as a core asset. We look at trends, we look at measures, and we do some predictive analytics, and we look at the risks of the populations. Having said that, we also link them to SDOH measures. We look for, so funding is always based on this data analysis. I have a lot of people that will come and say, oh, well, can we, if we apply to a grant, then, we're getting, it's too general, or we're not getting enough of the story through. And that's because you have to do that data piece, and you have to figure out the need, but you have to be so specific. They're also community responsive care. And you guys will know that if you're going to the community, somebody told me this one time when I was presenting, and it stuck with me. And that was the fact that when you open your doors of your dental clinic in a building, you're opening for patients to see your system, right? Welcome to my clinic. This is the way that how we do things here, register, do this, then follow up, right? When you take a mobile clinic to the community, you're going into their neighborhood, you're going into their system. Therefore, you have to adapt to that, and your community will trust you just because you're doing that. So you're taking the system to the community, right? When we assess the model, we talk about specific things. We talk about looking at the data, using some GIS informed routing, locating these clinics where it makes sense, and then providing hybrid teams of providers, whether it is we're taking an actual dentist, or we're taking a provider that's going to do some screening, a nurse practitioner is going to do some screening, and then it's going to follow up at their provider. So it's a workforce hybrid team. I used to tell my staff, I worked 10 years with mobile clinics, and I used to tell my staff, be flexible, because here you don't know when it's going to rain, it's going to be cold, or the door is not going to be open, right? And so we have to do that. Also, make sure you have in your model some technology, of course, EHR connection, and then as well as some telehealth. Mobile clinics are great telehealth hubs, and they allow to a lot of communities. Sometimes we think we're allowing people to connect through telehealth because they can't access healthcare. But really what we're doing is we're giving them a tool to do it, right? We're not actually getting in and teaching them. So a lot of the mobile clinics serve as these teledentistry models. Make sure we're looking at what gaps we're closing, and then that's what's going to dictate your model of sustainability. Then engage and deploy. I call it kind of the Nike kind of way. Just go do it, right? Like right now, we can't think of, oh, well, how many days have to pass until I have to go and deploy? Just go do it. Do some community engagement, of course. And to me, community engagement should really be called community responsibility, because what I many times did was, I'm not going to present to you a program that I'm doing, but rather I want to give you a responsibility to do the program that I'm providing to your community, right? So make sure that you give roles and responsibilities to your community partners. Make sure some of those are going to be champions and they're going to help you out. Also, dictate your ROI, right? So it is said that whoever is receiving the return should be part of the investment, right? So make sure you are communicating with these agencies and telling them, hey, we're going to your community, we're going to your schools. Talk to the school district and say, we're going to your schools. We're targeting 5 schools. It takes us $1,500 per day to deploy this mobile clinic. Then what's 1,500 times 5 schools times 200 days that we go out in a year, right? And what that's going to give you is it's going to say, okay, help us provide the care that we need. And then also, of course, dictate your outcomes, your metrics. What are you trying to accomplish? If you don't know what you're trying to accomplish, and this is a very good exercise. If you don't know how many visits you're trying to accomplish to your mobile clinic, but you're just going out there, you're not going to get there. Somebody's going to say, wait, you only have done 500 visits? Well, it's because you didn't do the homework or trying to figure out how many visits really would it take for it to be a satellite clinic. And then maintain and optimize. Of course, start maybe demonstrating, piloting, and then do a scalability roadmap, and how far will you get to after you deploy. And then you rotate services and you do it again, right? And I used to say to my staff, they're like, well, not a lot of patients are coming to this location. Well, it has wheels, right? Move it, right? Let's move it. So that's just kind of the process of mobile healthcare programs. So yeah, so this one is showing actually something interesting that we do as part of our programmatic kind of way of deploying mobile clinics. We don't just gather the data and then say, okay, I'm going to go to this community. We actually do some heat mapping. And heat mapping is really what it does is it allows you to put all the disparities together that you're trying to accomplish. This is just an example. This one is done in North Carolina and areas with patients that have morbid obesity and diabetes and are struggling with food insecurity. Once you have that heat map, then if you go to the next slide, please, then we will see the deployment of mobile clinics. So you see the little white vehicles around those areas. And we say, if we rotate these around these heat areas, then we have a target. We have a plan and we can logistically put them somewhere. Then we'll figure out they're going to get to be sustainable because we know exactly who we're serving. So next one. That's
Okay.
Adam.
Yeah. So I'm going to take over now. And one thing I wanted to kind of frame this as is this is not a either or. It's not. I'm going to go through some things. I won't spend a lot of time on each slide because I imagine the audience is very familiar with a lot of these strategies. But I don't want people to think that this is a mobile approach. That means we can't do some of these other things that we know are modalities to increase access to care. And so when we think of things like medical dental integration, we have partners that are FQHCs that'll have a mobile unit where one side of it is primary care, one side of it is dental or primary care and behavioral health. Or we have primary care going out and doing things up to their scope, like caries risk assessments, fluoride varnish applications. It may be a primary care in name mobile clinic, but they're able to do some of that assessment and preliminary prevention dental work and then refer back to a brick and mortar, or refer over, some have a dental dedicated mobile clinic that they can refer to. So next slide. So again, there's a lot of things to consider. I think most of us know this, but we'll set up the slides, but just some things to consider when we're thinking about medical dental integration and cross-training and practical considerations with the workflows. But I'll save time on this one. Go next slide. Other things, Maria talked about community engagement. And so that, it's not, whether you're talking about primary care or you're talking about dental, to make the most predictable, successful program, how are you engaging the community ahead of time? Are you using things like home visitors and community health workers, social workers? If you have public health nurses or public health hygienists that are there embedded in communities, are we using things like patient navigators and care coordinators? There's a wonderful program in Gastonia, North Carolina, called Integra. They have about 5 mobile units. They've chosen to do completely school-based as their model. They do only prevention. They go to a number of schools. It's financially sustainable. They refer back to the brick and mortar for comprehensive care on the dental side, but through intentional and very committed, and they're putting the resources to it, patient navigators. The patients that are referred over have about a 85 to 90% show rate as opposed to a no-show rate. And so, using these different strategies can be incorporated. And again, that's why I want to say it's not an either or, it's a yes and. Thinking about these other people, the provider team, especially if you're an FQHC, you may already have some of these providers on staff and integrating them into the care delivery process. Next slide. Again, this is just fun because I did this myself out back about 10,000 of these up a few years ago. But this was just some community-based education. We empowered our home visitors in the state of Georgia to use. They got to drop off these care packages through a maternal and child health initiative we did for new moms with or pregnant patients to deliver care both for the infant and the parent. We did some education through these flip books that go through the home visitors going into clients' homes and doing oral health education. Again, this could be an extension, not a replacement for things like mobile. Next slide. And then teledentistry, Maria mentioned this. I think a lot of us, when teledentistry first emerged, we envisioned a provider in a brick and mortar and a patient at home sitting on their couch with an iPhone and doing some sort of essentially a phone call. A lot of patients, especially in rural areas, they don't have connectivity. They may not have a device that is capable of this. And so a lot of our mobile clinics, whether it's behavioral health or dental, I think of the Paul Glassman model, going out where you have a provider like a hygienist doing screenings, assessments, doing an asynchronous evaluation, and then coming back and doing his or her scope of practice and prevention services. They really serve as a community hub. So it's teledental in name, but the patient is still going to an access point to receive these services. So again, extension of mobile services. Next slide. So when we think about designing a program, it's really important to not just think, hey, I want to do something good for my community. I want to do some dental. Let's work to get a mobile unit and we'll figure it out from there. A lot needs to be done up front to identify things like the population you're trying to address. Do you want to be focused on children? Do you want to be focused on adults? If it's children, are you going to do school-based care? Are you going to partner with Head Start centers? Are you going to do prevention only of children and refer back to brick and mortar? Or are you going to do comprehensive services? If you're doing adults, are you doing elder care? How is the mobility challenge? Literally, the mobility challenge of maybe leaving a elder care center to get on a mobile unit is going to be addressed. A lot of our mobile units use pretty robust, but still portable carts that can be taken off if need be and go into a residency place. And so thinking through this. I think the key is thinking through all these steps ahead of time, rather than getting all the energy ahead of time and then showing up day one and be like, okay, now what? How are we going to staff these? What type of care teams are we going to use? Are we going to use hygienists and dentists combined? Are we going to use a combination of primary care and dental care if we have a two operatory? How are we going to do provider training? We really, really, really encourage something with our our program advisory groups is to really simulate patient experiences ahead of time. So you're not out there in the community on day one and thinking, oh crap, we forgot about this. We didn't think of this. Go through simulation models. Simulate unexpected problems, emergencies, something goes out, so that it is a little more manageable than showing up and then all these things just popping up without any kind of preparation. How are you going to look at sustainability and continuity planning? Are you looking at reimbursement? Are you trying to reimburse through Medicaid? Are you trying to do grants and make this somewhat of a free or charitable program? We all want to do the most care for the lowest cost for people in the community. But if the door's shut down and they can't be open, then nobody can get helped. And so it is really important to be intentional about how you're thinking about these models. Are you evaluating? Are you looking at quality metrics? I mean, this is key even in brick and mortar, of course. But how do you know the impact you're making if you're not measuring it? If you're not looking at ways to improve, if you're not setting benchmarks and goals, if you're not being intentional with your roadmap of where you're trying to get to, how many patients a day are you trying to see? How many, what type of services are you trying to offer? If you're doing some sort of value-based care, are you achieving, the metrics you're setting for yourself? And then again, integrating other care models and how we can systematize this in the best way possible. Next slide, please.
Adam, can I ask a quick question?
Sure.
Do you have a recommendation on where to find, the pieces you're talking about this that immediately comes to mind is like a flow chart. Do you have any sort of worksheet or resource that folks could follow to do this type of needs assessment that hits all of the pieces to consider for mobile that might not be considered for other programming?
Yeah. We do, and I don't think I have them linked in the presentation, but we're happy to follow up and provide some of those resources at the end for sure.
Okay, awesome. Thank you. I will advance your slide now. I wasn't trying to be hostage.
No worries. No, that's the point. And so this is sort of our approach, and this is what we do internally with our organization. But really, we would be more than happy for people to adopt it broad scale. There's enough service need out there that hundreds of organizations could kind of come from this approach, and we think there would still be needs. So we try to systemize things as much as possible. When you're designing mobile programs, even from the manufacturing side, if you're doing too a la carte, and okay, for this organization, we're going to put endodontic equipment, and we're going to put this in there, and the particular provider likes this type of system of doing, he wants to do crowns, and there wants to be a lab. That is wonderful, but it becomes, when you add complexity, it adds challenges. So as much as you can standardize things, we believe in that approach. Both actually in the actual manufacturing process, I've learned a lot about from the vehicle side, making sure there's parts available, make sure there's service technicians available. That's something we have like a client services team, because we know kind of the death knell of any program is when they go down for whatever reason, a provider leaves, something breaks, and it just sits there for first a day, and then a week, and then 2 weeks. And then all of a sudden it's like, well, maybe we should pull that provider off the mobile unit, put them back in the brick and mortar. And before you know it, a year's gone by, and they're thinking of, how can we just get rid of or unload this mobile unit? So we really think about every friction point along the way to make sure that mobile program is up and running in the community. You've built, ideally you've built trust in the community that you're going to be there. And all of a sudden you stop showing up one day for whatever reason, and they'll give you a little bit of grace. But, as that extends further and further, both on the operational side, but also the trust of the community side, really makes it hard to get that program back up and running. So, where are things like I said, looking at workflows, looking at your provider teams. I really advocate for having dedicated providers as opposed to, okay, we're going to pull Dr. Smith from this brick and mortar clinic this one day. We need him. We're going to have Susie, the hygienist, from this clinic one day. She's not used to working with this. Now is Dr. Adams, and that challenge is hard enough in brick and mortar. So really be intentional of how you're designing these teams. Hopefully the team is really a mobile dedicated team, or if they're not 100%, they know every Monday and Tuesday we're going out to the clinic and we have the same operator driver, we have the same same assistant, because that just makes the workflow that much easier. We tend to partner with community health centers. That's our primary partner of choice, but we work with rural hospitals. We know that community health centers really know communities based on their structure. They're community led, they're community driven, they have community leadership on the board. Um, we do things like help forward deploy community health workers, but if they already are embedded in the community and they have that aspect, then we're certainly happy to defer to them. A couple of other adjunct areas where we realized there was challenges that we've tried to stand up some resources is partnering with Maria for a global mobile healthcare research consortium. So if a organization is looking for grant funding but doesn't have the capacity, maybe doesn't have a grant writer, what can the research consortium do to identify grants? Can we help them write the grant? Can the research consortium apply for the grant directly and help fund them? Can we develop some research projects to collect some data? Usually that's going to be a component of grants. We're working right now, for instance, looking at Campbell University and East Carolina University to reach some migrant farm worker populations and looking at potential research projects we can do with that. We also are looking at creating a global mobile medical association to do things like you're doing right here. How can we connect programs that are operating in silos? You may have a wonderful program that's sustainable and has the best practice models, at one part of the country, and a new program is trying to stand up on the other part of the country, and there are no way they could connect. So we're looking we've already established a 501c3. We're looking at launching at the Q1 of next year and collecting wonderful programs through a membership where they can do things like project echoes. We can do co-learning. We can share resources, share best practices to make sure that we're all in this together and kind of learning along the way as people are developing wonderful models. We have a paradigm program that is kind of the future. I'll let Maria talk about later if we have time. But ultimately, what we're trying to do is create a system that is somewhat scalable. Obviously, every state has different regulations, scope of practice, different rules around teledentistry. So we can't make a perfect prescription, but what we can do is give high-level guidance that will give the best chance of success within a given state, and then share those practices across states. So next slide. So again, thinking of workforce solutions, depending on supervision laws in your state, or is this going to be a hygienist going out with a teledentistry, again, a la the Paul Glassman virtual dental home model? Are you going to have hygiene-led days where you're doing all the prevention and then having teledentistry with the dentist going back out in the field? Are we doing referrals back to a brick and mortar for maybe comprehensive care? How can we do cross training? We talk about our drivers as something that we call operators, because we feel like the driver doesn't need to just show up. It's wonderful. We appreciate driving to the site, but then it's inefficient for that person to then sit there for 7 hours and then drive the mobile vehicle back. Is it a member of the care team? If so, they're jumping right into delivering care. If it's not a member of the care team, I've visited Piedmont Health in North Carolina. Their driver was not a dental person at all, but they cross-trained her to help with patient intake, then wipe down chairs, take dirty instruments over to sterilization, escort the patient out. Every member of the team is functioning to a full top of their scope capacity at all times. When we're recruiting, again, make sure people are aware these are mobile programs, give them some grace and some training ahead of time, so you're not just showing up on day one, not knowing what to expect. Make predictable schedules. Like I said, don't have it where somebody is going into a brick and mortar, 2 weeks straight, then all of a sudden it's Monday morning at 7 a.m. It's, hey, we need you on the mobile unit. That, as a provider, that adds stress, that adds complexity. Predictability and autonomy with a provider being included is key to a successful program. And then how can you do upskill to provide resources, training that again continues to help build out the skills of these teams. Next slide. When we're looking at FQHCs especially, sustainability and finances are always a key issue. How can we look at things like the prospective payment system, where you're getting paid on per an encounter model? FQHCs are used to this in brick and mortar. Adopting that to a mobile clinic is key. If you're going school-based, can you scale? That's usually higher volume. Can you do prevention at scale? And how does that transition to workflows? If you have key community partners, maybe you are sending the mobile unit out there to the First Baptist Church on Sunday at 2 o'clock, because that's where everyone's going to be. Maybe you're going to the fire station or the YMCA. Can you partner with large employers? Like I mentioned, the migrant farm worker pilot that we're looking to pilot. Housing orgs. They have the connection to the people community, and let them be a leverage for you to be that trust builder and that connector for you. Other opportunities for alternative payment models with MCOs if you're an MCO-led state. How can you do data sharing with entities, maybe academic institutions that can help and empower you? All again say there's not only one size fits all. We do recommend typically starting small and growing. Don't try to boil the ocean at once. Look at pilots with small workforce, small targeted areas. Maybe don't say we're going to go around the whole state day one. It's going to be hard to find providers. It's going to be hard to find drivers that are living in hotels. Start with the at-risk community, like targeted community, like Maria was saying earlier. Do those evaluations and then see how to scale from there. So next slide. So again, talking about sustainability, look at a blend, typically same way you would a brick and mortar. Look at, your Medicaid, your, is it possible to contract maybe with an MCO for a pay for performance model? Look at grants. Maybe you can supplement it with things like a 340B program if you're an FQHC. See if you can offer something like an ED deferral incentive to maybe an MCO. How can you, meet metrics if it's a HEDIS measure or something of a dental quality alliance measure, something that is important to them. And you can show that you can improve on that by being community-based and going out in communities with that. So next slide. So I'll try and Maria, we only have about 10 minutes, I think, to talk about some of the ways we highlight programs and learn best practices.
Yeah, this is a cool program. I love this part, actually. So I had some time to sit with the CEO of Orange Blossom Family Health, which is an FQAC in Florida. And they have 8 clinic facilities and 5 mobile clinics. And so what a little bit of what I can summarize what some of our findings were, some of the findings that I had as he was talking. So he has a school-based program, and it operates under contracts with the schools, which guarantees that all students are served regardless of insurance status, which is absolutely wonderful. Because one of my questions was, do you operate on a word partnership, like shake hands, or do you actually have contracts? So they do work with specific contracts. They partner with other areas other than schools, like nursing homes, retired communities. And then one of the things, so they do several things in mobile. Primary care, school-based health, dental services, HIV testing, counseling, school-based behavioral health. And what he mentioned was that providing that integrative care was amazing, because once the parents were consenting to do one thing, they were excited they could do it all, right? And so that was one of the things. At the heart of the program is the Sealant Initiative, right? And focuses primarily on prevention and early intervention. As a staffing model, they had 1 hygienist, 2 dental assistants, and one of those dental assistants actually drives the dental mobile clinic. And then they're mostly dedicated to the mobile program, but there is some time when they have to cross over and go to the back and forth from the building to the satellite clinic. They have the first mobile clinic that they did, they converted into a full dental focused clinic. And then the second, they had grown so much. The second one, they put 3 operatories. And the third mobile clinic now has 2 operatories with cabin-free and more equipment. That's what they decided they were going to have. And then they're building a 4th one just for dental. So you can tell what the need is there. They also, one of the things I wanted to mention was their financial model. Their financial model is number one is a revenue generation program. All right, so he said it to us. He said, you know, dental service generate income that offsets the uncompensated care, particularly for the homeless population. So they have a model where they figure out how much can they get out of reimbursement, and then how much will it be compensating other programs. And they're actually their payer mix made a shift. That was, to me, that was one of the great points he made. He said, historically, the clinics were serving populations that were 85% uninsured. Now the total today, the payer mix is 50-50, insured versus uninsured. And that is largely due to Medicaid coverage among school children in a dental program. So that's one of the things that he said was what made his program grow so much. They've done some market testing with mobile clinics. So which means is they go put a mobile clinic somewhere in the community, and they work like that for 6 months to a year. And then they decide it's time to put a brick and mortar there. So they also do some market testing, and they are looking to future opportunities is more on the integrative health model with the behavioral health services that they thought for schools was important. If you go to the next slide, I know you guys can't see it, but anyways, the recommendations that they're giving other problems is number one, secure your work in schools. Number two, use mobile to test markets. Number three, focus on prevention, track profitability, adapt as community grows, change, be flexible, expand, thorough the police. So, which means take your data and expand in the right places. Don't say, oh, well, I'm going to more places, but I'm seeing less patients, right? And then diversity, future services, diversify the future services, which means what they're trying to do is trying to get to more integrative care and say, what if we do this? What if we do that? The one thing that I'll never forget that he says that they're looking at a healthcare like great report card. And what it is, it includes 2 dental visits for every school year. So if you think about it, they not only include primary care, the behavioral health screening, but then now they're including 2 dental. So it's a way of diversifying what they're doing. Okay, so that's it for our presentation. I don't know if we want to jump to question and answers, and maybe I'll end with what we're doing for as the next generation of mobile. If there are any questions, maybe we stop here just to see.
Yeah, I was thinking maybe jump to the final poll, and if people can stay on, or if we want to have a follow up separately about our paradigm project, we can. So hopefully this is more of a positive question than the challenges before. I don't know if we've inspired any thoughts or ideas, but we want to see what you think as far as after hearing this feedback about what you're thinking in terms of how it could be adapted into your communities. And as people are responding, Liz, I don't know if there's questions in the chat. I know we only have a few minutes, but if people want to come off mute or something as we are also asking these, maybe we can do that now as well.
I think that would be great. I don't have my chat available, but I know Shayla will chime in if folks popped things in there. But please feel free, if you have a question, to just come off mute and ask. I see folks are also typing, so take your time.
I have one quick question. Maria, when you were talking about the heat map, I did not catch the name of that. Could you let me know what the name of that was, that system software?
Yeah, so we work with a partner called Foresight, and they do predictive analytics using heat maps. So to have said that, I work with GIS mapping over at the university, and didn't cost a lot of money to kind of put it together. So I wouldn't go all the way to the whole partnership of the big the big providers of that. There's an AI analytics, there's so much to do in GIS mapping, but I think if you have access to GIS mapping, it's absolutely wonderful, and you can do the heat maps using it. So
And what I would add to that is, I we all know that dental data on a mass scale isn't necessarily as good as some other health indicators. There are things like health provider shortage areas for dentists you could look at. The county level health data has some. There's what I think University of Wisconsin maybe. But also you can look at comorbidities that we know are affiliated with higher risk. So low socioeconomic tracts, if you food insecurity that Maria had on that other slide, comorbidities around diabetes, hypertension. These are going to be populations that are going to be more likely to have dental problems as well. And so you can almost use that as an indicator for strategic mapping as well, even if the dental data isn't directly accessible. Yeah, I like some of the ideas coming out. Leverage dental hygiene and nursing students, provide faculty supervised care. Yeah, we're actually looking at that right now. I had a call with the dental college about 4 hours ago to see about student rotations and getting that incorporated as part of training. And again, nursing students, we talked about integration of care. They can do oral health assessments. There's a lot that can be done from our medical colleagues on their side as well. I love the idea of partnering with WIC and pre-K Head Start centers. We use mobile programs in Georgia to satisfy the screening requirements for Head Start, and it was done with great success.
Yeah, these are really fantastic takeaways. I appreciate everyone taking a moment. I am going to go back to our slides so that we can make sure we share CEU instructions, next step instructions. But I see that folks are still typing, and I want to reiterate that this will remain open, and we will share out with the group afterwards. So if you are still typing or haven't yet started, please continue to do so, even though I'm popping back to slides, if that's okay. Okay, so this was our poll, and Maria and Adam, that we will post these slides, and I know that there are some pieces here on kind of future of mobile and what you see. So I will just note here that for folks who we're skipping some slides at some end, for folks who are here live with us or folks who are watching asynchronously, if you have questions about these future slides, perhaps they can follow up with either of you for further discussion.
Absolutely.
Okay.
Our contact info is there, and we're both happy to follow up with any and all of you that have questions that you should think of now, later, or anytime in the future.
Okay,
yeah.
fantastic. Okay, so CEUs are available for today's session, as we said. Shayla is going to pop the link in the chat. If you are watching this asynchronously, it is available. The link is already on the Academy below this recording. So you'll follow the link. I'm going to go to the next slide and show you what you need to click through. If you do not need CEU for today's session, but you have thoughts on the session, we invite you to fill out the evaluation anyways. We always want feedback so we can upgrade and improve. Stay tuned for our next Rooted seminar, this is a typo here from us. We have our next and final series of 2025 in November, and then we will be launching our 2026 series. This is just a note here. When you follow that link that Shayla shared with you, you click through, kind of continue, and all of the sessions will be there. So you want to scroll down and make sure you hit on this October session if this is the CEU. And again, if you haven't attended our other seminars this year, you can go back up and watch those asynchronously and get CEU there as well. A couple other notes from AIDPH. This week is our LGBTQIA+ Oral Health Week. It's our 4th annual. As I mentioned at the top of the call, there's a fair amount of intersectionality among our communities of focus. There are many resources we are posting throughout the week. So if you haven't seen those, we encourage you to take a look. I think Shayla is going to post a link in the chat to our resources. And you can also follow us on LinkedIn to see our partnerships and the resources that we're sharing throughout the week. In the same vein, we have an upcoming Veteran Oral Health Week in November. If you are interested in partnering with us as a nonprofit, or another partner who wants to share their support of veteran oral health, Shayla's going to pop another link in the chat. You can reach out and ask us questions, and we invite you to keep an eye out for that wonderful content upcoming in November. So please join me in giving a big thank you to Maria and Adam. We are so thrilled and thankful for your time and your insight and your expertise with us here today. I love a model. I love really kind of a workflow to follow. So I'm really excited about the content you shared. And I'm excited for folks to check out your research and the resources that you have. So thank you for being with us here today. And for our participants, thank you for your dedication to our rural communities and taking some time to think through partnerships and workflows that you can implement for your own community. I hope everyone has a wonderful day.
Thank you for having us.
Yes.
Thank you.
Yeah.